Good evening. My name is Dr. Bob Conversar, and tonight's topic is routine oral cancer screening, a win for the patient and a win for the practice. The numbers can be quite frightening. More than 30,000 cases of oral cancer are diagnosed every year in the United States, with more than 8,000 deaths every year. Over 59% of the patients die within 5 years. So if we turn that around, we're talking about a 5-year survival rate of less than 41%. That's pretty frightening, and that's pretty sad. That's an indictment of our profession, that so many people are dying from something that we can look for and we can successfully diagnose at an early stage, but unfortunately we are not doing so. More cases of oral cancer are diagnosed every year than ovarian, cervical, or pancreatic cancer. Quick, think of somebody who died of pancreatic cancer. Quick. You can think of a few people. Think of Stephen Jobs. Think of Patrick Swayze. Think of people that died of ovarian or cervical cancer. You can think of Gilda Radner from Saturday Night Live. Think of somebody that died of oral cancer. Oh, well, see, that's going to take a minute or two. You don't really know, but I'll give you a list. Oral cancer is the 6th leading cause of cancer deaths in males in the United States. Frightening. More people die from oral cancer than from cervical cancer or melanoma. And here's the kicker. This is something that should wake everybody up. One person every hour of every day dies of oral cancer in the United States. I'm talking to you from New York City. Right now, it's a little bit after 7 p.m. I got up to go to work 6 a.m. in the morning. I've been up 13 hours. So since I got up this morning, 13 hours ago, how many people in the United States died of oral cancer? 13. That's frightening. So think of what time it is in your time zone. Think of what time you got up, and you can figure out how many people have died from oral cancer since you got up this morning. It's a large number. What do Babe Ruth of the New York Yankees, George Harrison of the Beatles, and the famous actor Humphrey Bogart have in common? Well, they all died from oral, pharyngeal, or throat cancer. Any sports fans tuning in tonight? Tony Gwynn, Hall of Fame right fielder for the San Diego Padres. He got hooked on snuff, and he died from oral squamous cell carcinoma. His family is in the midst of suing the snuff tobacco company, alleging that they made him an addict, and he could not kick the habit, and he passed away from being addicted to tobacco use. Jim Kelly, Hall of Fame quarterback from the Buffalo Bills. When we're finished with this webinar, why don't you go online and why don't you Google Jim Kelly oral cancer? You'll see that Jim Kelly has had about a half a dozen different operations to treat his oral squamous cell carcinoma. Half a dozen operations. For those of you that are baseball historians, Curt Flood is the father of baseball free agency. He was a player for, I believe it was the St. Louis Cardinals, and he was going to be traded to the Phillies, if I'm not mistaken. And he did not want to be traded. And in those days, there was something called the reserve clause in all baseball players' contracts. And he questioned it, and he sued Major League Baseball. It went all the way to the Supreme Court of the United States. The Supreme Court sided with Curt Flood, and that's what issued the ruling that started the beginning of baseball free agency. So that's Curt Flood. He survived oral squamous cell carcinoma. Brett Butler, pretty good outfielder for a number of years, started his career with the Atlanta Braves, finished up with the Dodgers and the Mets. He survived oral cancer. Curt Schilling, famous pitcher with the Boston Red Sox and Arizona Diamondbacks, also survived oral cancer. So there's a whole bunch of people out there, people you probably weren't aware of. Entertainment figures, Bogey, Humphrey Bogart Jr., Sammy Davis Jr., Bruce Paltrow, Roger Ebert, Jack Klugman. Let's talk about Humphrey Bogart. When he passed away, he was only about 84, 85 pounds. Just wasted away to nothing from oral squamous cell carcinoma. Sammy Davis Jr., part of the famous Rat Pack in Las Vegas. That was Sammy Davis Jr., Peter Lawford, Frank Sinatra, Dean Martin. Sammy Davis Jr. was a famous actor, singer, dancer. He developed oropharyngeal cancer, went to his physician. His physician said, I can treat you, but you'll never sing again. Sammy Davis Jr. said, I'd rather die. And he did. Bruce Paltrow, father of Gwyneth Paltrow, beautiful actress. Bruce Paltrow died of oral squamous cell carcinoma. Roger Ebert, the famous film critic from the Chicago Sun-Times, passed away from oropharyngeal cancer. Jack Klugman, very famous actor from a million different things, from Playhouse 90, from a whole bunch of Twilight Zone episodes, from The Odd Couple, from Quincy, died of oropharyngeal cancer. Sigmund Freud, you always see pictures of Dr. Freud with a cigar. Well, Sigmund Freud died of oral cancer. President Ulysses Grant is the only United States president to die of cancer. And Grover Cleveland survived verrucous carcinoma of the hard palate. So here's Roger Ebert. He had a complete mandibulectomy, and the last couple of years of his life, he communicated through a computer-synthesized voice, and anything he wanted to say was typed on a keyboard, and the computer would synthesize a voice for him, the way Stephen Hawking, the famous physicist, communicated for most of his life. So that's Roger Ebert. Oropharyngeal cancer can be deadly. Good news and bad news here. The good news, 80 to 90% survival rate if caught early. The bad news, only 30% is caught early. We've got to catch it early. If we can catch it early, we can save lives. It's nice to put in a filling. It's nice to put in veneers. It's nice to put in implants. Nice to do all these things. There is nothing that should give you a sense of accomplishment as much as finding a lesion and saving someone's life. In the past 3 decades, there has been a 60% increase in oral cancer in adults under the age of 40 years of age. 25% of these cases do not fit into the high-risk profile of smoking and drinking. We must do a better job of early detection. The good news, general practitioners perform 60% of all periosurgeries, 48% of all bony surgical extractions, and 40% of all apicos and root amputations. These are all much, much more difficult than biopsies. The bad news is that general practitioners perform only 17% of all biopsies. Why make the oral surgeons rich? It is a simple, easy procedure to do. It is a high-ticket item to perform, and you'll be doing your patients a tremendous service. So we're going to talk about how to look for these lesions, how to biopsy them. Schaefer, who wrote the standard textbook on oral pathology back in the day when I was in dental school, stated that the advantages of a biopsy so far outweigh its disadvantages or potential dangers that biopsy is seldom contraindicated, which means when in doubt, cut it out. If you don't detect it early, the average malpractice award against dentists for non-diagnosis, missing the cancer, was over $1 million. And most of us dentists just carry $1 million, $3 million in malpractice insurance. So if you don't find it and you get sued, you're teetering on the edge of what your malpractice company is going to pay out. How do we do a better job of early detection? There are a whole bunch of things. Oral ID is one device, Velscope is another, Identify 3000 is another, Goggles is another, and there are more on the way. They all work pretty similarly. They all have their own advantages, disadvantages, different prices. That's something for you to discuss, for you to determine, for you to take a look and see which of these devices would work best in your offices. Dysplasia begins at the basement membrane. Before you can see it, fluorescent visualization can. So the first picture on the left, you see where the cancer cells are, but you can't see it visually. You need to palpate. you need to use your fingers. Look for a bump or a lump. Then the next picture is moderate dysplasia. The oral cancer is getting a little bit bigger. Then on to the severe dysplasia, then oral squamous cell carcinoma. We usually find it here when we need to be able to find it here. This is very, very difficult to find if you're not trained, but this is something that the fluorescent visualization devices, such as the 4 I just mentioned, are expert at finding. Has fluorescence visualization work? It's tissue fluorescence. You know how Diagnodent works? Different tissues fluoresce at different rates depending on their biological activity. Cancerous tissue is much, much more mitotically active than normal tissue, which accounts for a different fluorescence rate. So, light will cause tissue to fluoresce. The color is characteristic of the combination of the tissue structure and the fluorophores, or the things that are in the tissue that are going to glow. So what we're looking here is something that's fluorescence visualization negative. What we have here is there's something going on, some changes in the tissue fluorescence, and that helps determine areas where there are changes to the cells. That doesn't necessarily mean it's cancer. It means it's something we need to investigate. It means it's something we need to biopsy. So this would be fluorescence visualization positive. Fluorescence visualization positive here, a Visilite exam with toluidine blue, for example, does not show the extent of this lesion. The top left photo, you really can't see a lesion there with the unaided eye. With the toluidine blue, you see part of the lesion, and with the fluorescent visualization, you see how much larger the lesion actually is. So these devices work quite well. And in a few minutes, we'll go over the literature defending the use of these devices and showing how effective and how efficient these devices are. Visilite missed this lesion completely, which can happen. I'm not knocking Visilite. Visilite performs a very important function in many offices, but what we see here under fluorescent visualization is a severely dysplastic lesion. You think this is just a little fibroma? So if you've done biopsies before, you might just cut that out yourself or refer that to an oral surgeon. Well, is it just a little fibroma? Let's take a look. When we take a look at it under fluorescent visualization, there's an area of carcinoma in situ and mild dysplasia, and you would only know that after the biopsy. So if you just biopsy the fibroma, you're going to miss areas here, so the margins of that biopsy may not be clear. And we'll talk about that in a few minutes. What happens if your biopsy margins aren't clear? Some people don't do biopsies because they worry about that. That's absolutely nothing whatsoever to worry about that. We'll discuss that shortly. So this is the way a surgeon would use fluorescence visualization. There's a lesion there on the tongue. So the surgeon is marking the lesion with an indelible pencil, and that's where he would do his biopsy. And then he'll use the fluorescence visualization, and he will see that the extent of the lesion is significantly more than what he could see with the unaided eye. So he would end up changing his margins to accommodate the entire area that the fluorescence visualization shows. If you have a lesion, a cheek bite, a lip bite, a tongue bite, and it looks normal under fluorescence visualization, it looks green like the rest of the field, that's fine. Nothing to worry about. But if you have something that looks maybe like a lip bite or a cheek bite or a tongue bite, or maybe there's a sharp cusp and you think the tongue is rubbing up against the sharp cusp of a tooth, and it fluoresces very differently Well, that means that's something that needs to be evaluated. All right, you're interested, but you're like most dentists. You have a closet full of can't miss gadgets. How do you make money on this one? At the end of the day, whatever device we have, we're going to need to have some sort of return on investment. So what's the return on investment for these devices? I'll tell you in a minute. But think of all the things that so many dentists have in their closet that they buy, they use it for a couple of times, then it goes into that closet, never to see the light of day again. Years and years ago, people were interested in TENS devices, transcutaneous electronic nerve stimulation devices used for analgesia. That sort of went by the wayside. Other people bought something called a Carasolve device. This device shot out an amino acid liquid, which was supposed to dissolve decay, and all you had to do was spoon out the decay. That didn't last very long. So there are plenty of devices that lots of dentists have tried over the years that just didn't work out, didn't have the return on investment, didn't work as advertised. So how do we know if these oral cancer detection devices actually work? How can we make money? How can we get a return on investment for these? Well, there's an ADA code for this. And the ADA code has been around for a couple of years. And the code is D0431. So let me tell you my experience billing out D0431 in the metropolitan New York region. Some MetLife policies, not all, but some MetLife policies will pay up to $150 every 24 months for patients 40 years of age and over for this type of examination, which is something that many people do for free. Guardian Life Insurance, not all policies, some policies can pay up to $150 on adults 40 years of age and over every 24 months to do this type of examination. Once again, not every MetLife policy, not every Guardian policy, not every Cigna policy, but some do. I have yet to find a Delta dental policy that pays for it, but hopefully one of these days. So let's look at the return on investment for these devices. Let's see my return on investment. I'm a big believer in high tech if the high tech and only if the high tech brings something of value to my practice and brings something monetarily to my practice. So let's say you do 1,000 screenings a year. And I'll show you in a few minutes how we get to 1,000 screenings a year. It's not that hard. Let's say the cost to the patient is $25. You charge only $25 for this. So your revenue is $25,000. Let's say the cost of the unit is about $2,000, depending on which unit you get. Your 1 year return on investment is $23,000. Your 2 year return on investment is 23 plus 25, because you've paid for the device, $48,000. If you charge $50 and do 1,000 of these, your 1 year return on investment is $48K. Your 2 year return on investment is $98,000. You charge $75, you see what the figures are. 1 year ROI, $73,000, 2 year ROI, $148,000. So these devices, when used properly and when marketed properly, with good intentions behind the marketing, not just to make a buck, but to actually find lesions in your patients, can be a wellspring of new money for your practice. So how do you get to 1,000 patients a year? It's not difficult. Let's say you work a 4-day week. 6 patients a day have a fluorescent visualization exam. That's 24 patients a week. That's 96 patients a month. If you work only 10 months a year and you take 2 full months of vacation a year, that alone is 960 exams. So you can get to 1,000 or more exams a year without too much difficulty whatsoever. Let's take a look at what Gordon Christensen's clinical report said. Volume 5, Issue 7, July 2012. The CR conclusions. Fluorescence is a viable adjunct to mandatory, see that word, mandatory oral cancer screening because it reveals abnormal cells before they may be noticed visually. It allows you to see things before you can see them with the naked eye. It promotes thorough examination, and I'll talk about that in a minute, and is faster and easier than oral dyes or brush biopsies. Cancer screening must be a routine part of oral exams, and clinicians should inform their patients of this valuable service. So let me play devil's advocate for a minute. Let's say these devices are useless. These devices are just toys. They're just fancy flashlights. They don't really do anything. It's just a way to get a couple of bucks out of a patient. The reason that's absolutely wrong is because when you give this to the hygienist is going to spend an extra minute or 90 seconds or so looking. And if the hygienist or the doctor spends an extra 60 to 90 seconds looking, they might find something that they would have missed otherwise. So it promotes thorough examination. Very important, critically important. But we'll go over the literature in a little while to show you that these things actually do work. And we have a bunch of literature that shows how important these devices actually are. So this is the New York Post, one of New York City's newspapers, founded by Alexander Hamilton in 1801, been published continuously since 1801. And this was the cover story a bunch of years ago. Sex gave me cancer. Michael Douglas admitted that he was a sex addict. He had unprotected oral genital sex with someone who had HPV in her genital tract, and the HPV from her genital tract ended up going into Michael Douglas's oral mucosa, and he ended up with oral pharyngeal cancer. And he's not the only one. Plenty of patients end up with HPV-induced oral squamous cell carcinoma. It's a lot more common than you think. The day this hit the stands, and for the next 2 or 3 days afterwards, it was practically impossible for me to perform routine dentistry. I had patients coming to me from left and right saying, you know, Dr. Bob, that oral cancer exam that I always say no to, you know what? Can I come in today and have the oral cancer screening? Very, very powerful. You want something a little bit more powerful, something that you can put in your office and have everybody watch every single day? How about let's listen to Michael Douglas for a minute.
In a world where cancer is almost a daily part of the news, one cancer isn't heard about enough. Oral cancers are increasing in the U.S., and as in my own case, most people know little about them. Like many, I thought that this was a cancer that impacted much older people who had used tobacco most of their lives. While that's still a problem, the fastest growing segment of the people developing oral cancers are young non-smokers. A very common virus, one responsible for the vast majority of cervical cancers, is now identified as a cause of this rapid rise in oral cancers. Thankfully, in a fast, inexpensive, and painless visual and tactile screening, a medical or dental professional can often identify early-stage disease. So please, the next time you visit your dentist or your medical doctor, ask for this simple screening. Finding oral cancer in its earliest stages may save your life.
How about that, ladies and gentlemen? I think that's one of the most powerful public service addresses I've ever seen in my entire life. I have this going in my operatories, in every hygiene room, on a continuous loop. It is impossible in my office for any patient to have a prophy without listening to Michael Douglas give that warning. And you can download this for free from anywhere online. You can download it from the Oral Cancer Foundation. You can get it from YouTube. It's around, and it's easy to download and easy to put onto an iPad or any other device. and just let your patients see it. Very, very powerful. The Oral Cancer Foundation is an organization you may want to look into. They promote oral cancer screenings. And if you sign up with them, they will send you patients just for complimentary oral cancer screenings. And very, very often, these patients that come in for the complimentary oral cancer screenings end up becoming your patients for life. So it's a win-win situation. Critical point. Journal of the American Medical Association, not the ADA journal, the AMA journal, January 2016, Fluorescence Visualization Guided Surgery for Oral Stage Oral Cancer. And what did this AMA paper say? It said the use of fluorescence visualization significantly reduced the rate of local recurrence in oral cancer. So these things do work. And there is a ton of peer-reviewed literature out there that discusses that. We don't have time to do this in 1 hour, but there is a lot of material out there that show how important these devices are, how valuable these devices are, and how successful these are in finding things that you would not be able to find otherwise. Very important point. Does this fluorescence visualization detect cancer? The answer is no. It detects abnormal tissue. Doesn't mean you have cancer. It means there's something abnormal, something different, something that must be evaluated. So if you see something, what do? Biopsy. Learn how to perform biopsies. Do them yourself. Why make the oral surgeons rich? Performing a biopsy is not a difficult procedure at all. At the end, I'll give you a link to a website that has 2 papers that make this cookbook fashion, how to perform a biopsy, step 1, step 2, step 3, step 4, step 5, step 6, and we'll go over the steps briefly over the next couple of minutes. So what is a biopsy? Biopsy is nothing more than removal of a piece of tissue for microscopic examination. There are 4 possible outcomes, and I want you to listen carefully. One of the reasons that dentists are very leery about performing biopsies is they think they'll make things worse. But you can't. Let's say it's benign and you got it all. Well, congratulations. Are you done? Absolutely not. What do? You recall the patient periodically to make sure it does not recur. Number 2 possibility, it's benign and you did not get it all. Well, congratulations. What do? You recall the patient periodically to see if it recurs or if it regrows. Very often, if it's a benign lesion, it doesn't necessarily have to be totally removed. That's a decision between you and the oral pathologist. Let's say it's malignant and you got it all and your margins are clear and your margins are clean and everything's perfect. What's the next step? The patient is referred to a head and neck surgeon, just to make certain. Let's say it's malignant and you did not get it all. What's the next step? You refer the patient to a head and neck surgeon. So no matter which of the 4 possible outcomes happen, you're fine. There's nothing for you to worry about as long as that patient is referred appropriately or that patient is recalled appropriately to follow up. Nothing to worry about. So why do we biopsy? Well, determine if a lesion is inflammatory, reactive, systemic, or neoplastic. Inflammatory reaction, some sort of reaction going on here. Systemic, this is a patient that is a kidney transplant patient. This is a systemic result of cyclosporin, which is an immune system suppressant used in transplant patients. Neoplastic, this is Kaposi's sarcoma in an AIDS patient. Why biopsy? To determine whether a neoplasm is benign or malignant. If it's malignant, to type it, grade it, stage it to determine a prognosis and a treatment plan. How many of you see these little irritation fibromas on the tip of your patient's tongues? What do? You stare at it. Sometimes it stares back at you. Sometimes it winks at you. To remove this little irritation fibroma is a 2-minute procedure. Not a problem at all. It does not affect the patient's taste. It does not affect the patient's speech. It does not affect anything whatsoever. Malignant? Benign? We don't know. That's why we biopsy some sort of lesion on the roof of the patient's mouth. Types of biopsies: excisional, incisional, oral cytology, and aspiration biopsy. We're not going to talk about oral cytology or aspiration biopsy. We're going to talk about these two, excisional and incisional, which is what most people do most of the time. Excisional is you remove the entire lesion. So, a little fibroma, lipoma, some sort of oma, you don't know what, just remove the whole thing. Incisional biopsy, partial removal of the suspect tissue. You don't remove it all. Well, why would you not remove it all? Maybe you should take everything out? Well, there are a few reasons. Number one, the lesion is too large to remove easily. So you wait until you get the diagnosis. If it's benign, you may want to leave it and watch it. Or there are multiple sites in the patient's mouth, so you sample a few different lesions. This is a patient that had a lesion, maxilla, mandible, left side, right side, floor of the mouth. Before we do a total excision of this, we're going to do a couple of incisional biopsies, maybe one here, one here, one here, and the same thing on the other side, and drop down to the mandible, do a couple on the mandible, lower left and lower right. And if they all come out benign, we don't have to subject this patient to a long, tedious procedure to remove everything. If, however, it comes back malignant or pre-malignant, then this is something that I generally would refer to an oral maxillofacial surgeon. So there are a bunch of different ways to perform biopsies. You can use a laser, you can use electrosurgery, you can use cold steel, you can use a punch, you can use cryosurgery. However you want to do it, absolutely fine. However you feel most comfortable, however you are best trained to perform the procedure. I prefer laser, gives you a bloodless field, excellent visualization of the surgical site, decreased vulnerability to post-op infection, decreased scarring, no wound contracture, less post-op bleeding, less post-op pain, usually no need for sutures, no need for post-op meds. People always ask me, doesn't using a laser mess up the specimen and make it difficult for the oral pathologist to evaluate the specimen? The answer, of course, is yes and no, depending on the training you receive. If you are a well-trained laser user, you will be able to create a margin that has minimal to no thermal damage whatsoever, and the oral pathologist won't even know that a laser was used. If, however, you are not great at using a laser, you don't understand how lasers work, you don't understand how to use the correct wattage, the correct millijoules, the correct hertz, then you may end up messing up that specimen. So if you're trained, not a problem to use a laser. If you're not trained, can have a major league problem using a laser. So we have to talk about what we're going to biopsy, where we're going to biopsy, when we biopsy, and when we refer. Because I don't biopsy everything I see. Some things I'll just take a photograph of and watch. Other things I'll send to the oral surgeon. What do you biopsy? Well, whatever looks suspicious. A red lesion or a white lesion or a lesion that's red or white, a bump or a lump, a macule, a papule, a pustule, a nodule. What are these things? A macule is usually a flat lesion. A papule is usually a raised lesion. A pustule is a raised lesion with pus in it, and a nodule is a raised firm lesion like a fibroma. What do you biopsy? Well, a lesion that doesn't respond to local treatment within 7 to 14 days. Maybe there's something that you can do locally to see if the lesion goes away. We'll discuss that in a minute. Lesions that interfere with function. Lesions that show sudden enlargement or sudden growth. Lesions that have no apparent etiology. You can't think of what has caused that lesion. Lesions that are red or white or red and white. lesions that are deviations from normal anatomy, lesions that are hyperkeratotic, lesions that are unilateral rather than bilateral. Where to biopsy? Well, you're a dentist. Anywhere from the lips to the tonsils is your area. Gingiva, buccal mucosa, alveolar mucosa, tongue, palate, lip, wherever you want to biopsy, as long as you have the ability to. Simple gingival biopsy on the buccal here of number 30. Alveolar mucosa. Tongue biopsy, very, very simple to do. Palatal biopsy. Lip biopsy. Buccal mucosa biopsy. When do we biopsy? After no response to conservative treatment, or after an appropriate course of antibiotics or anti-inflammatories if you think it's necessary, or after removal of the local irritant. Maybe there's a sharp cusp tip causing an irritation fibroma. Maybe the tongue or the cheek is being rubbed up against a sharp cusp tip. Maybe the tooth broke, maybe a little piece of the tooth is kind of sharp and it's causing a little irritation. Smooth that area down. Take a look, see what it looks like a week later, 10 days later, 2 weeks later. Technique. And at the end of this webinar, I'll tell you where to go to get all of this all written down in a couple of easy, simple CE programs. I will also discuss where you can get hands-on training on biopsy technique. If this is something you're interested in, stay tuned and we'll go over that. I give courses all over the United States and all over the world on biopsy technique for general practitioners and specialists. So the technique, number one, you assess the patient. Is the patient somebody that you feel comfortable working on, or does the patient have multiple medical problems? You assess the lesion. Is it something that you feel you can visualize easily, or is it something too difficult to visualize the entire margin? You anesthetize, you make the incision, give the patient the post-op instructions, and you speak to the pathologist. Assess the patient. What's the patient's medical history? Any drugs used, including aspirin? Well, are you going to worry about clotting problems? Any habits? Is the patient a chronic cheek biter? Sexual history, multiple partners, history of atypical pap smears with partners, something that's difficult to discuss. However, remember Michael Douglas, remember HPV, human papillomavirus. This is something that you've got to try to tease out from the patient during the history. Know the medical history. Is that drug-induced gingival hyperplasia, or is there something else going on there? This is a patient that is a kidney transplant patient, and she is taking cyclosporin to prevent rejection of the kidney. As a result of the cyclosporin, she has cyclosporin-induced gingival hyperplasia. Is that what it is? We don't know for certain. We're going to remove this tissue and we're going to biopsy a piece because this looks, strangely enough, very similar to a leukemic gingivitis, and transplant patients have a higher incidence of leukemia. So just because this is a transplant patient, you can't say with any definitive reasoning that this is all simple gingival hyperplasia secondary to cyclosporin. Most likely is not 100%. That's why you biopsy. Know the medical history. Are those aphthous ulcers, or does the patient have Crohn's disease? Take a look at that. Is that a recurrent aphthous ulcer? Is that a Crohn's disease, Behçet syndrome, any of a whole bunch of GI disturbances that cause patients to have breakouts like that? Know the medical history. Is the patient an uncontrolled diabetic? Well, if they're an uncontrolled diabetic, I'm not going to do the biopsy because it's going to be a little more difficult. The patient may not heal as quickly or as easily. There may be some postoperative sequela. So an uncontrolled or poorly controlled diabetic, let the oral surgeon deal with that. They're better able to deal with medical problems like that than many general practitioners. Is the patient immunocompromised? You're not allowed to discriminate against AIDS patients. On the other hand, if the patient is immunocompromised, healing may be a little bit more difficult. So that's something that you may want to discuss sending to an oral surgeon. Is the patient pregnant? What trimester? Always get something in writing from the OBGYN that says that you are okay to perform whatever surgical procedure is necessary. Find out what type of anesthetic can be used, and on and on. Always get it in writing. Have it faxed to you. Uncontrolled diabetic? Got lots of problems here. Immunocompromised? This is HPV, human papilloma virus-induced focal epithelial hyperplasia. This is something that is definitive of a malignancy in an AIDS patient. Pregnant? Is this a pyogenic granuloma, a pregnancy tumor? Probably. You willing to bet your life on it? I'm not. Lesion assessment. So you've assessed the patient. Now it's time to assess the lesion. Are the borders completely visible? Can you see the entire lesion? Does the lesion start in the maxillary tuberosity and extend distal to the hamular notch, somewhere where you can't see it? Well, if you can't see where it ends, you're not going to be able to biopsy it. Send it to the surgeon. Can you avoid underlying anatomy? Are there any blood vessels in the area? Are there any nerves in the area? Are you unfamiliar with the normal anatomy? If there is a lesion on the mandible between the lower left first and second premolar, I'm not going to biopsy that because that's near the mental foramen, and I don't want to risk hitting the mental foramen. So you've got to know your normal anatomy. Will you be able to obtain hemostasis? I have a laser. Simple for me to obtain hemostasis. If you don't have a laser, you use a blade. Maybe a problem, maybe not. How well do you know your normal anatomy? Do we biopsy this? Yes or no? This is benign migratory glossitis, otherwise known as geographic tongue. No, you take pictures of it, you watch it, and it changes all the time. Biopsy this? Yes or no? Wickham striations. Wickham striations means that's lichen planus. There's two types of lichen planus. There's erosive lichen planus, and there's a more benign lichen planus. Got to be careful with this. Now, the fact that you can perform an excisional biopsy on this does not mean that you are curing these patients. You have to make these patients understand 100% that you're removing this lesion. It is not a cure. These are dermatopathologies that occur in the mouth. These are usually immune system problems. These will usually come back again and again. So don't make any promises that you're going to remove this and it ain't coming back, because the odds are that it is. Biopsy this, yes or no? You've got all sorts of little yellow vesicles here. Well, that's Fordyce granules, perfectly normal. Sebaceous cysts intraorally. Biopsy this, yes or no? That's just a prominent linea alba. And maybe because the patient is a little bit overweight, the patient has chunky cheeks, and the patient bites his cheek a little bit, the linea alba is a little bit more prominent, and maybe more prominent on one side than on the other side. Biopsy this, yes or no? Do a history. Has that been there all along? Well, the patient may not know. Feel it, palpate it. Is it hard, indurated? Well, then it's a torus. Is it soft and squishy? Well, then it's not a torus. Hemostasis, exsanguination, I love that word. Bleeding to death in the dental office is no fun. Can you obtain adequate hemostasis easily? Is the lesion in a vascular area? Are there arterioles in the region that you need to be aware of? I've done capillary hemangiomas with a laser. It's a simple thing. Could you obtain hemostasis with your technique? How about hemostasis here? Once again, this is Kaposi's sarcoma, something we rarely see anymore, but achieving hemostasis on these lesions, not the easiest of things to do. Vascular area in the midline? No, that's not a very vascular area. Not a lot of blood vessels here, not a lot of arteries or nerves here, not a difficult area to biopsy. How about here? Well, we're not in the midline, but we're not right up against the teeth. Right up against the teeth, you have the posterior superior alveolar arteries and veins, and you've got the nerves. And if it's right by the teeth, I would punt. I would send that to the surgeon. If it's halfway between the teeth and the midline, well, then I would go ahead and I would biopsy that. So you must know your normal anatomy. Came out perfect. The posterior superior vessels would be right around here. So I've got a nice area away from those vessels where I can work. Could it be malignant? There are 6 properties of malignancies. Now you have to use this with a grain of salt, with a little bit of common sense. The mnemonic device I use is FIGRUB, F-I-G-R-U-B, FIGRUB. F, fixed. The lesion is fixed to the underlying tissue. It's not freely movable. I, indurated. The lesion is firm to the touch. It's hard. G, growth. The lesion has grown rapidly. R, red. The lesion is totally red or red and white. U, ulcerated. The lesion surface is ulcerated. B, bleeds easily. Now you have to use these things, once again, with a grain of salt. If a patient comes in with a large, fixed, indurated lesion on the roof of their mouth, well, it's a maxillary torus, so you don't have to do anything about it. So use these with a grain of salt, use it with a little bit of common sense, and you'll be fine. Clues. If the lesion is painful, that usually means it's inflammatory, not malignant. The problem with cancers is that they're usually not painful until they're really large. If the lesion is bilateral, it's usually anatomical, not pathologic. If the patient has a fever, it's viral or bacterial. If there are multiple lesions, it's probably viral. Clues. Sudden weight loss. That's not a good sign. Swollen regional lymph nodes, not a good sign. Poorly demarcated margins, not a good sign. These 3 are kind of definitive, not 100%, but they kind of steer me towards this is probably a malignancy that I'm going to send to the oral maxillofacial surgeon. Technique, anesthetize. Outline the lesion in your mind. Where are the borders? That's where it's great to have these all cancer detection devices because you can look and see where the margin is going to be. Grab the lesion with pickups, or instead of tissue pickups, college pliers, cotton pliers, anything like that, I use a suture to hold, and you'll see that in a minute. Excise the lesion, ensure hemostasis, and make sure you give post-op instructions, including a follow-up appointment. This is the tray setup. What do you have on your tray? Biopsy jar. Where do you get that? The oral pathology service. Gauze, cotton rolls, suture material of your choice, mouth mirror, tissue pickups, any sort of tissue pickups, college pliers, whatever you want to use, needle holder or hemostat, scissors, suction tip, a blade handle, and a 15 blade. I use a laser 99% of the time, but I always have a 15 blade and a handle ready to go. So here we go. Biopsy jar from the oral pathologist for free. 2x2 gauze, cotton rolls, suture material, your choice, 15 blade and handle, suction tip, suture scissors to cut the sutures, needle holder, mirror, and these are something called Adson, A-D-S-O-N, Adson forceps. You can use these, or you can use any tissue pickups you have, cotton pliers. I used to use these, now I just put a suture through, and you'll see that in just a minute. Anesthesia. Block is always preferred over infiltration. If you infiltrate too close to the lesion, the solution can distend, and then it may be a little more difficult for the oral pathologist to figure out what he's looking at. And if the solution is deposited irregularly, if you use a laser or electrosurge, those devices may cut irregularly. If you must infiltrate, inject at least a centimeter away from the lesion. So, if this is the lesion, I'm not going to anesthetize all around here. I'm going to stay a centimeter away over here, centimeter away over here, centimeter away over here, and 1 centimeter away down here. Because if I anesthetize here and I deposit the solution irregularly, I may put some solution here, maybe a little more anesthetic here, maybe even more here, and a little less here. So whatever device I'm using to cutting, it will cut irregularly. But if I anesthetize here, 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 then I'll be able to cut much more regularly. So stay about 1 centimeter away. Outline the lesion. If you're using a laser, use a pulse mode to outline the lesion. This way you can see how the tissue reacts to the laser. If you're not using a laser, you can outline the lesion with a marking pencil, with a marking stick. Pre-op, outline the lesion, and connect the dots. So if I'm using a laser, I may outline the lesion, and then I may take a look. You know, this is too aggressive. I could bring that margin in a little bit. You know, this is too aggressive. I can bring that margin in a little bit. That's one of the many, many advantages of using a laser. But can still do this with a plain old 15 blade. Nothing wrong with that. Technique. If you're doing an incisional rather than an excisional biopsy, narrow deep wedges are better than wide superficial because there might be malignant tissue deep in the lesion that you'll miss if you just go superficial. Take wide margins, especially the first couple of times using a laser or electrosurge. You want to take wide margins. Very important with laser and electrosurge biopsies. Technique. Minimize the spot size if you're using a laser, or a small spot size if you're using electrosurge. That will give you less width of thermal effect on the tissue. Apply traction. Use the tissue pickups, lift up an edge, and pull. Once again, rather than tissue pickups, I use a traction suture. For me, it's easier. The dental assistant is going to hold this, one little suture through it, and as the assistant is pulling this way, pulling gently, I'm undermining from this way. This is where I'm cutting from, and the assistant is applying traction there. Keep pulling gently as you use the laser, the electrosurge, the blade, whatever you want to use to undermine the lesion till the lesion is free. There we go. Keep pulling. Goes right in the biopsy jar like that. Does not affect their speech, does not affect their taste, does not affect anything whatsoever. Granulates in absolutely perfectly, no problem whatsoever. Obtain hemostasis. Defocus if you're using a laser, or reduce the power to seal the wound, or just hold it with a 2x2. Post-op treatment. Vitamin E. Some people like to put vitamin E on lesions like that. That's up to you. Other people like to use aloe vera. Some people use nothing. That's entirely your choice, your call. Post-op instructions, give to the patient. Post-op appointment without question. Have them come in 1 week later for a post-op. Fill out the biopsy report for the lab. Please check this step. Is the specimen fully submerged in the biopsy jar? You got to make sure it's fully coated by the liquid in the biopsy jar. Otherwise, it could dry out. So, request for tissue examination, your information, patient's information, what you think it might be, what the history is. This is the biohazard bag. In the bag goes the biopsy jar, and in a pouch behind this bag goes this, and you put it in a FedEx mailer, goes right to the lab, and you're good to go. Post-op appointment, examine the wound for proper healing, remove any sutures, review the pathology report with the patient. A benign report does not mean that the job is finished. Whether it's benign or malignant, discuss it with the pathologist. If it's a benign incisional biopsy, do you remove the rest of the lesion? Do you leave it? I'm not smart enough to know the answer to that. That's why I rely on my oral pathologist. In case of a benign incisional biopsy, benign idiopathic white lesions have a malignant transformation rate of about 17%. Do we leave it? Do we watch it? Do we remove it? Once again, that's the call of the oral pathologist, not my call. Benign report, recall the patient periodically to ensure that the lesion does not recur. Malignant report, refer to an oral maxillofacial surgeon or a head and neck surgeon. Did you fill out the biopsy data sheet? Is the specimen totally immersed in the formalin? Did you review the post-op instructions and set up the recall appointment? Even if you don't put sutures in, set up the recall appointment. Remember, all tissue removed from the body should be sent for pathologic diagnosis. That's the law in virtually every state. So what do? I'll discover the lesion. I will watch it for 10 to 14 days. I don't biopsy anything immediately upon seeing it. If the lesion resolves, I'm a genius. Recall when appropriate. If the lesion does not resolve, when it doesn't resolve, I'll go through the FIG rub. But if you're going to watch it, please take photos the correct way. Measure the lesion. How do you do that? Here you go. Always put a perio probe in the field to measure the lesion, so that if the patient comes back in a week, in 10 days, in two weeks, maybe I'm standing a couple of inches further away from the patient, so it'll look smaller. Maybe I'm standing a couple of inches closer to the patient. Maybe my focal distance is a little different, so I don't know if it's bigger or smaller. If I've got that perio probe there, I know exactly what the length and width of that lesion is, so I know if it's grown or has not grown. If the lesion is still present after 10 to 14 days, if the patient appears healthy, the lesion appears benign, biopsy it. If the patient is medically compromised, or you do FIG rub, fixed indurated grows, red, bleeds easily, then we send it right to the oral surgeon. Ulcerated, of course, is the U. Refer to a surgeon and follow up. And make certain that you get the patient to the surgeon. I prefer to use only oral pathologists rather than general pathologists. Call your local dental society, call your local dental school, ask your friendly oral surgeon, call the American Board of Oral Pathology. Do you bill for medical insurance? Many practices do. That's up to you. There are plenty of resources to change the dental codes to the CPT and ICD codes. Not a problem. These are just some things that I've done over the years. Neurofibromas, actinic cell carcinoma, giant cell fibroma. Done a whole bunch of things over the years. So I will discover the lesion. I'll observe it for 10 to 14 days. If the lesion resolves, brilliant. I recall when appropriate. If the lesion is still present, if the patient is healthy, lesion appears benign, I'll biopsy and follow up. If the patient is medically compromised or FIG rub makes me think, I'll refer to a surgeon, make certain the patient goes to the surgeon, get the pathology report, follow up with the surgeon. Me and my grandpa, thank you for listening. Of course, that's not my grandpa. That is Albert Einstein. I'm a laser guy, so Albert is the godfather of lasers. Here's my information if anybody wants to email me. My email is so dumb, you'll never forget it. I use a laser. My name is Bob, and I'm a DDS. So my email address is laserbobdds. You can find a list of seminars at fullspectrumseminars.com, but shoot me an email. A couple of questions before we go. Are there any suggestions on specific CE you can take to learn more about biopsy techniques? Take a look at Full Spectrum Seminars. There are some courses there. I give them all the time. Or just email me. Do I ever observe for a week to 2 weeks? Absolutely. We went over that. If it's an aptus ulcer or whatever it is, or is it better just to biopsy? It's never better to do surgery. It is always better to watch and observe. You can always do the surgery a week, 10 days later. A week to 10 days in an oral cancer case is not going to mean life and death. How long does it take to master the use of a laser? Depends on the laser you're going to use. That's a whole nother story. I give laser courses, 2-day laser certification courses. So by all means, shoot me an email. How much border do you recommend taking on excisional biopsies? 2 millimeters is fine, depending on what you're using. If you're using a laser and you're new, take more than 2 millimeters. You're using electrosurge, more than 2 millimeters. Using a blade, 2 millimeters is fine. And that should just about wrap it up. Any other questions? Otherwise, thank you for listening, and hopefully I will see you at a biopsy course in the near future, or even better, a laser course sometime in the future. LaserBobDDS@gmail. Hope to see you soon. Call me, email me anytime you want for any more information. Thank you very much, and I hope you got something out of this, and have a great evening.